What I appreciate about our patients with CLL or SLL is the consideration that they receive a cancer diagnosis, and the best thing for them to do is actually nothing. There's a large population of patients that we don't recommend any type of treatment. We recommend that they establish care with an oncologist, that they have a relationship with those care teams.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between.
Hello, and welcome to the ONS podcast. I'm your host, Lenise Taylor, Oncology Clinical Specialist at ONS. And today we're talking with Caitlin Murphy, Chief Nurse Practitioner at Dana-Farber Cancer Institute in Boston, Massachusetts, about an overview of chronic lymphocytic leukemia for oncology nurses. This episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation linked in the notes. Thanks for joining us, Caitlin. I'm looking forward to learning more about the current state of CLL.
Well, thank you for the invitation to join you and to talk about something that I'm really passionate about.
Can you provide us a brief overview of what chronic lymphocytic leukemia, or CLL, is and explain how it's different from small lymphocytic leukemia?
So CLL and SLL are often confused as an overlap of a syndrome, or should they be distinguished as being different? They do manifest in different ways, and that's what drives their nomenclature. When we think about CLL, we think of the presence of more than 5,000 clonal lymphocytes in the peripheral blood. And when we think about SLL, we think of the presence of lymphadenopathy with or without splenomegaly, and also can have those clonal lymphocytes circulating in the peripheral blood. So while phenotypically they look different in the way in which patients present, biologically, there's a lot of overlap in the way in which it's diagnosed and characterized, and subsequently how it's cared and managed. CLL cells are cancer cells that are located in the bloodstream, in the bone marrow, and then they can also aggregate in the lymphoid tissues, so those very small bean-shaped structures that are within our body to help fight off disease. And in many cases, they're circulating and identified when people are feeling relatively well. And at times they can be identified when people have some symptoms.
So let's talk a little bit about pathophysiology of CLL, how it develops and why it develops.
Some of the common risk factors are some environmental exposures or occupational exposures, chemical exposures. If, for example, in certain farming communities where pesticides, that can definitely contribute to the risk of developing CLL. There's some consideration for high levels of radon exposure or exposure to Agent Orange. So our veterans, both from Vietnam War, but also in consideration of more recent in Iraq. So there's definitely a consideration that those types of exposures increase the risk of developing CLL. And then there's also a familial component where those with a first-degree relative have approximately a 3 to 8-fold increased risk of developing CLL or another type of lymphoid neoplasm. So starting to understand a little bit more of a connection between familial patterns, but not necessarily as really well established, but definitely notated as an increased risk of developing it.
You talked a little bit about some of the common risk factors for developing CLL. You talked about occupational and pesticides, that sort of thing. Are there some specifics that we can look out for that might play into us thinking that this might be a higher risk person?
I think most of it is pesticides. So farming or agricultural communities, I think that's mostly the most well-established. And then other chemicals in terms of radon or Agent Orange can be considerations for those environmental or occupational exposures.
What are some cytogenetics and molecular features that are most important for prognosis in CLL? And you mentioned a little bit about being hereditary. Is there a little bit more that you can talk about in relation to that?
When we think about CLL, SLL, it's a really heterogeneous disease. And so there's a lot of variation. And a lot of the research that has been really, I think, transformative in the last couple of decades of work is understanding which patients have higher risks of needing therapy or actually having their CLL cause more profound symptoms. And then there's also what we've observed, historically is there's a large population of patients that progress quickly, have variable responses. And so trying to understand the variation of the disease as well. And those things are really helpful when we look at the cytogenetic and molecular features. And I think that that's something that really is emphasized when we initially establish the diagnosis. We can identify the abnormal count of lymphocytes on a complete blood count. And then additionally, as part of follow-up, we typically will get a flow cytometry to identify those abnormal lymphocytes. So that's what starts kind of that diagnostic approach to understanding who has developed CLL. And then once that diagnosis has been established, we start to think about some of these more specific features. And so a lot of testing that is really recommended. FISH is recommended, gene mutation analysis is recommended. And I think when we think about FISH testing, it's usually performed at the time of diagnosis. And it's also recommended that it's repeated at a time of needing a new therapy. This looks for different chromosomal abnormalities or mutations. And so some of the most common ones for CLL is the deletion of 17p, and then additionally the deletion of 11q, deletion of 13q, and then trisomy 12. So those are some of the more common ones that we're looking for with the FISH testing. And that gives us a better understanding of the prognostic impact, but also some of the therapeutic implications and which therapies are going to be best based on these features. We also look for tumor protein 53 gene mutation, so TP53. So I think in general, from all cancer biology, it's well understood that TP53 gene mutation, unfortunately, bodes a poor prognostic factor in that it tends to characterize a more aggressive disease feature. And so this test should be done at the time of diagnosis. And then subsequently, if there's ever a need to change therapy, this is a test that we would recommend be repeated because it can change, just like the FISH testing with some of those chromosomal abnormalities. These have the potential to change and evolve during a patient's journey with CLL. If the TP53 gene mutation is mutated, as well as having the presence of deletion 17p with those higher risk features, we also understand that chemotherapy, traditional chemoimmunotherapy, is not effective. So when we think about initial diagnosis and features and characteristics of the disease, these can be really, really essential to kind of understanding which trajectory we're going to be guiding patients along. And then we also have a third test that we do, which is called IgVH. It's an immunoglobulin heavy chain, and this is a gene that is tested and it does not change. So unlike the others, the IgVH does not change. That gene mutation doesn't change. And this is done often at the time of diagnosis or before a treatment is being considered. This also has a correlation with the response to traditional chemoimmunotherapy. And that can be that if this gene is unmutated, traditional chemoimmunotherapy is much less effective. And so generally we kind of avoid those types of therapeutic approaches. And overall, we think that if it's mutated, it actually has a more favorable prognosis for that IgVH mutation. Those are some of the larger implications for when we think about molecular features of the disease and where it kind of leads to next steps for a lot of patients.
So we talked about some of the risk factors and we talked about the molecular features and the hereditary. Are there certain groups of people in general who might have a higher incidence of CLL?
Yes. Generally, CLL is diagnosed when in the median average age of diagnosis is in the 7th decade of life, so typically in the 70s. But I will share that over 90% of people are diagnosed at age 50 and above. So this tends to be a diagnosis in the 6th, 7th decade. It's extremely rare in children, although it has been observed. And it tends to happen more in men. It's twice as likely to develop in men than it is compared to women. And then individuals who are white are more frequently affected by CLL than other racial or ethnic groups, followed by people of color, and that includes Black, Hispanic, Native Americans. It's rare in Asian populations. And then in terms of higher disease association with European and especially of Ashkenazi Jewish descent.
What are some common signs and symptoms someone with CLL might present with during a primary care visit? And can patients actually be asymptomatic when diagnosed?
Oftentimes, patients will present for routine pre-op testing, for surgical clearance, or they'll come in for some other type of screening modality, like a mammogram or some other component of rationale to get blood work or imaging. And so if a patient comes in for a complete blood count as part of pre-op testing, they may see these abnormal white cells in number. And so that precipitates often follow-up or additional evaluation. And then sometimes we can find that in the setting of the SLL, where there's more of the presentation with enlarged lymph nodes, it can be identified from a routine screening mammogram. Some of those very small axillary lymph nodes can be identified from that piece. So oftentimes patients do present without any type of symptoms. I think that's part of the challenge, that we can definitely educate and understand how to support them as they move through this care trajectory. The other piece, when patients do have symptoms, some of the symptoms that they're commonly going to report or bring to their care team's attention is fatigue, shortness of breath, bleeding or bruising easily, profound night sweats. So these are drenching night sweats night after night, where people find themselves are kind of changing their bedclothes. They're taking a shower in the middle of the evening. In some cases, they can have weight loss. And then additionally, frequent infections. So these are patients that have recurrent upper respiratory infections requiring courses of antibiotics. And so subsequently prompts additional evaluation. So to varying degrees can these symptoms present, but this is kind of the constellation of potential symptoms that we have seen patients present when they are diagnosed with CLL.
Yeah, and like you mentioned, a lot of those are ones that would take someone to their primary care provider on a regular basis. They're coming back with, oh, I've got another sinus infection, or I've just been really tired. And I think one of the things that a lot of people think about is, from an oncology standpoint, why did the primary care doctor not go further down a diagnostic path? But when you think about it, so often people really just do have recurrent sinus infections. So how can we work with our primary care teams to alert them as to when to go down a further testing pathway?
Oftentimes when I see a CBC, that complete blood count, I think in general and in an older adult population, I would have a really low threshold to consider doing laboratory work in that way. And so I think that's where we sometimes will find, if someone has some fatigue, we will then find that they have this abnormal white count, and then potentially they may have some mild anemia. And there's a lot of reasons why patients can present with anemia or fatigue. I think those are really challenging symptoms, but I think warrant a lot of follow-up or kind of deeper dive, as you say, in terms of really understanding anemia it's not something that just happens as you get older. Really, there's a root cause to why anemia happens, and being a detective to find out what it could be. It's multifactorial. There's so many things that could contribute to it, but I think worthwhile. And I also think when we consider the approach, the invasiveness of getting some of these additional studies, I think that that's part of it, where a CBC can be done pretty readily. I think we always think about access, and we have all these really, I just talked about all these molecular studies and all these really, really specific studies that warrant kind of a more robust academic or partnership to be able to do some of these additional tests. A routine CBC can be done anywhere. And so the access to be able to do that and to be able to follow up and say, okay, there's an abnormality. Let's repeat it, validate that it's still abnormal, that it's not a variation that someone was ill, and that's why a CBC can be off. But really pursuing it repeatedly, I think that that's part of where you can kind of balance access and really pursuing a diagnostic approach. The flow cytometry, which is additional testing to look at the evidence of these, abnormal proteins on the surface of these cells, those can be done also from peripheral blood. And so again, it's not as invasive as when we think about most hematologic malignancies where we consider bone marrow biopsies, which can be hard to get and have done and provoke a lot of anxiety for patients around comfort. And we're able to actually diagnose these patients without, if they have the circulating presentation as part of CLL, we don't need to do a bone marrow biopsy unless there's some characteristics that we see on the blood that warrants further evaluation. So I think we can get a lot of information with relatively minimally invasive evaluation. From the SLL perspective, where patients present with more of the lymph nodes being enlarged, oftentimes we are able to get a core biopsy to be able to evaluate and make sure that this is a lymphoma in terms of the features in that way. And so it's not without some potential risks, but again, usually can be really well tolerated and can be done in a very wide array of centers.
You mentioned the CBC with diff, because a CBC without diff doesn't tell us much, right?
Correct.
FISH and flow cytometry. Are there other tests that we would look at when diagnosing these patients?
As part of the diagnostic approach, typically we'll evaluate for these molecular studies, cytogenetics, so FISH, flow cytometry, some of these specific gene mutations. There's some consideration for more nuanced testing related to measurable disease, which is a whole kind of topic that probably warrants a much larger conversation. But I don't think that would be part of our diagnostic approach to these patients, but definitely is a blood test that we consider as patients move through this journey, whether they require therapy or not requiring therapy or in an active surveillance perspective. And then we also think about additional studies that may be helpful to help support them. And so one piece that I would add to the consideration, we want to do a chemistry panel to make sure that we're not having any type of organ dysfunction, or when we see, especially with SLL, we can have peripheral adenopathy that's palpable on exam that oftentimes leads to the evaluation and workup. But if they haven't had imaging studies like CT scans, that's also quite helpful to kind of get a baseline understanding of the extent of, do they have lymph nodes? Do they have this mixed picture of a little bit of presentation in the blood, maybe with some small volume adenopathy? So we typically will also include CT scans. And then we also, in terms of some other additional blood tests beyond a CDC with differential, a chemistry panel to make sure that organ function is good, we look at LDH, which is lactic dehydrogenase. It's a non-specific inflammatory marker that can sometimes be elevated in the setting of CLL, SLL, and that's a nice kind of monitoring tool. It's a surrogate marker for what we think may be inflammation related or changes related to their lymphoma. We also consider something called immunoglobulin, so IgG, specifically in terms of that type of a protein. And this is important because CLL, SLL has a significant impact on patients' immune systems based on the disease pathology, where it impacts the T cells and your immune system functionality. That IgG can be correlative to some of those concerns around frequent infections. So even if patients don't require CLL, we call it CLL-directed therapies, where we're addressing the specific lymphoma, but we're trying to support patients to reduce the risks of other things. We think about IgG or immunoglobulin infusions, or it can be done as a subcutaneous injection in some cases. So looking at that as a monitoring and a supportive care measure for these patients, that's sometimes done as part of their evaluation and workup.
That makes a lot of sense. You mentioned doing your diagnostic testing and your scans to determine what the treatment plan for this person would be, or if it's appropriate for them to go under an active surveillance approach. Can you talk a little bit more about that?
What I appreciate about our patients with CLL or SLL is the consideration that they receive a cancer diagnosis, and the best thing for them to do is actually nothing. And so I think it's incredibly anxiety provoking, and there's a lot of adjustment and coping with a new diagnosis, but also related to what to do about it. And so when we think about the diagnostic approach, we get a lot of information that's incredibly valuable and helps us really to pivot and guide patients as to where they need to go and how we can best support them. And so we've had well-established studies that look to say, well, if we were to treat patients earlier or had different thresholds for consideration for treatment, do patients do better? And so there's a large population of patients that we don't recommend any type of treatment. We recommend that they establish care with an oncologist, that they have a relationship with those care teams, that they have routine lab monitoring with those complete blood count, the chemistry panel, and LDH. They have a physical exam, and they talk about supportive care and relative risk reduction based on things that they're more likely to develop because of the CLL diagnosis. There's a lot of work. I think it's really great that we can actually guide patients in a much more precise way, that you don't need any type of therapy at this point, and it may change and evolve in the future. And we have a better understanding of which patient populations are going to need therapy at some point, and some more readily than others. And some, unfortunately, present and need treatment right away. I think that's the nuance of the disease, that it's very different based on some of these features. And so kind of understanding the biology and the background to be able to really execute a plan with our patients that they feel aligns with their goals, and we are able to inspire some confidence as to, you don't need therapy and we can continue with this. It's phrased a couple of different ways. Some people find that active surveillance is best suits them, and so they're constantly in observation, or there's sometimes the perception that it's a watch and worry, that you're just waiting for something to happen. You're waiting for the disease to warrant therapy. So you kind of are holding on to every good day. Is today going to be the last one? And that's, really, as I mentioned, anxiety provoking to kind of cope with that. And then there's some people that really are, unless it's bothering me, I don't want to do anything. I don't need to think about it. And you really have to kind of prod and say, no, I should see you, just to make sure you're keeping up with everything that I think will help reduce potential infectious complications or other things in that way. So there's a time for active surveillance. There's a time for swift initiation of treatment. And that's really driven by the disease pathology, the disease characteristics, as well as the patient as well.
Probably what the patient's quality of life looks like with or without treatment, what their life expectancy is with or without treatment, that sort of thing weighing in. It's just like with all of our other cancer diagnoses, right?
Exactly.
Switching gears just a little bit, but can you talk a little bit about Richter transformation in CLL and why it's important?
Richter transformation I think, is challenging in that it's a relatively low incidence that this develops, but it can be very challenging to manage and treat. And so, as a bit of background, Richter transformation in CLL was first described actually, in the 1920s. And it was observed when there were these evidence of CLL, SLL as part of the characteristics, but then there was also this transformation or change into a more aggressive large cell lymphoma in patients who had that underlying CLL or SLL. So it became a much more aggressive presentation, and often it's a transformation into diffuse large B-cell lymphoma. So a very aggressive large cell, which has a very different treatment approach, symptom presentation, but it also could be a transformation to Hodgkin, which also is a more aggressive form of lymphoma. But even in that entity, that Richter transformation has the biological foundation of having evidence of CLL or SLL and transforming it, having evidence of that aggressive lymphoma. And so the long-term risk of developing Richter is growing because people are living longer with CLL, SLL than historically. We have much more therapies. People are staying, are living with this disease for many years, but it's a really challenging subset of lymphoma patients that the disease characteristics, it's very hard to treat. And it really, unfortunately, portends to a really poor prognosis. But I think it's always in the back of an oncologist's mind or that care team's mind when there's a sudden change in the symptoms or a sudden change in physical exam or blood work, that we do worry that there is always this potential that it could transform into that more aggressive large cell, although relatively rare in the general incidence.
Are there any predictors when you look at a patient that would say this person might be more likely to have a Richter's transformation?
Oftentimes, when we think about some of the features, where we think that they're more aggressive with TP53 mutation or the deletion 17p, although that doesn't always correlate, I think those tend to just have a naturally more aggressive disease course and maintain in the CLL defined entity. But I think the other piece is oftentimes when a patient presents pretty rapidly with new symptoms, we often will do a PET CT because I think that that's the most helpful in recognizing that FDG avidity and the SUV on a PET scan can really help us kind of narrow down into thinking this is something that is no longer behaving like SLL and really warrants tissue sampling. I think that's another key piece when we start to see things significantly change in symptomology or in laboratory studies. It's really important to get additional biopsy sampling because we do worry in some cases that this can transform. And so not just kind of treating it consistently, it's always going to be CLL and more aggressive feature. It's there a potential that this is not even CLL, that it's really transformed into something different and warrants a completely different treatment approach.
I live in a fairly rural area, and I know that it's also agricultural. So I know that this is an issue here, that we're a ways away from where people might actively be treated for or followed with CLL. So what are some of the considerations that you in a academic or in a very urban area that you might keep in mind with individuals who have CLL, who are living in areas that would make it not just rural areas, but would make it difficult for people to access treatment or active surveillance on a routine basis with you?
I mean, I think there's some benefit in some way that a lot of the ways in which we engage and monitor patients is really in more routine, readily accessible laboratory studies. We can get a CBC relatively easily with that differential. And I think that's a huge component of being able to monitor for kind of the disease status. And same thing with chemistry and LDH. I think the value of a physical exam is excellent. And so, in terms of a partnership with primary care or people that are maybe more localized to where people are receiving their care and really having a partnership to escalate. I had some patients that really live in rural areas and they say, I'll come to you once a year and I'll see my primary care on my other, and so facilitating that communication and that partnership. And so oftentimes if there is something that necessitates really truly an oncologist input, we can facilitate that, but really trying to have pretty simple, straightforward monitoring. And I think that's some of the benefit, that a lot of these specific tests that are needed don't need to be repeated every single time. I think that the piece that's going to evolve and change is actually something that we can monitor from a CBC. We don't need to be repeating the flow cytometry and TP53 and IGHV. Like, those are not tests that we have to routinely repeat often. So I think that allows for a little bit more accessibility. I do think that partnership with thought leaders and people that see this, I think CLL in that aspect is, the most commonly diagnosed type of lymphoma. And so building up that clinical acumen and partnership with when's the best time to really be coming. And I think a lot of the variation of follow-up is dependent on the disease course. And so I have some patients that I just see once a year, and that works out really nicely. It's not a huge burden to come into a regional main campus. Even sometimes twice a year can be challenging. So appreciate that. And so partnering with as best as we can, and facilitating some other telemedicine and pieces like that, which would be really helpful.
Those partnerships are key.
Yes.
How can healthcare professionals educate individuals with CLL and support them through their diagnosis?
I gave a lot of thought to this consideration because I think it really stems out of the variation of the CLL and the disease course, but also very much with the individual. Oftentimes I think about it in a meet them where they are, because I see this all day, every day, and I have a lot of comfort and clear understanding of things, and can sit with some ambiguity that patients sometimes really struggle with that. And so understanding their health literacy component, what they understand, how much they want to understand and learn. I can run the gamut of someone coming in and not understanding all components of a complete blood count. They've never had this blood test done. And then I have patients that are really well informed and really curious, and have gone down and found articles and are researching items themselves. And so I think understanding their health literacy and what they understand and where to build on that, and at what rate they would like to know and more and understand more. And I think too, a big piece around their perception of being action oriented. So I have some people that are doers and they want to do something. And so this active surveillance or watch and worry or watch and wait really paralyzes their coping. And so they want to do something. And so oftentimes that's really when I pull in some integrative strategies and say exercise is going to be always beneficial. The more active you are, the more physically fit you are. If you really want to do something, make sure that you stay hydrated, that you eat well, and you're engaged in a physical activity that you enjoy and can be consistent with. So giving them opportunities to kind of redirect how they sometimes cope with a new diagnosis or with change, and understanding that. And then I think too, a huge element of this is understanding these prognostic factors and helping them understand so that it can shape and give direction to that potential timeline for therapy. And I say that in a lot of different ways, and that you can't have a crystal ball. You can't exactly predict exactly, but there are definitely some features of the CLL, SLL that make me a little bit more worried and concerned that they're going to develop a need for therapy sooner than later. And there are some people that I can say with a fair amount of confidence, I think this is something that you're always going to have as part of your health, as part of your chronic conditions that you're going to manage and you're going to monitor and you're going to support in different ways. But I don't think that you're going to need active treatment. And then there's people in the middle that also, in terms of, you may need something now, you may need something later. You may have had therapy and now we're moving into a different trajectory. So I think understanding that framework, and really it's a shared decision of how they want to spend the time together during your visit. I think that's also the most helpful. And I think when we think about, if there's someone that's going to go down a treatment consideration, I think that that's where there's a lot of other elements that we think about in terms of their quality of life. You mentioned rural settings. I have, patients that live 5 miles away and still don't want to come into the clinic. And so you really have to understand where they want to spend their time, how they want to spend their time, what's important to them in terms of quality of life, financial implications of potential therapy, or just coming into a clinic visit for routine visits are not without costs. So I think understanding and being able to shape and give them some guidance. I think people like to be able to plan and put things in place of how to share this with their families and their support networks. And then there's always an opportunity to repeat and go over again, because there's always going to be some nuance of a detail that's new or different, or what they hear or what they respond to is going to be variable. And so having kind of your normative pattern of bringing up a lot of things with patients, and so that they can kind of probe and ask questions as to what really is important for them and answer their questions appropriately.
You start with your initial bucket, and then each time you see them or each time you have a discussion with them, it gets bigger because they've changed. Like they now understand this piece of it, but they don't understand this, or they have more questions, or they found more information, so they want more, or just as their disease progresses or changes. That's one of the things that I always found intriguing about this disease, is that it's different than a lot of our other cancers in how we approach the treatment. And so sometimes you have to change your mindset a little bit in how you're doing these sessions with patients.
It often, in some cases, is a constant reiteration of the same information, but people need that constant reassurance that nothing has changed in the interval of time. And so even in a relatively stable trajectory of the disease course, there's still some question. Okay, this is good. But now, or when they get into some statistics and they start to reach a threshold where, well, most people needed treatment after 5 years. Now I'm at that 5-year point. Does this mean that tomorrow I'm going to need something? And so they kind of build on their fund of knowledge of their own disease and their individual health changes too, in terms of things that we have to take into consideration that I wouldn't have otherwise. A new diagnosis of another malignancy, or a new diagnosis of some other type of health complication that factors into things. And so it's never a stagnant conversation, which I think is great. There's a lot of consistency and stability, but there's still a lot of variability in terms of how we can support these patients.
You mentioned a lot within that last piece about people accessing care, or financial components of their care, or how their families or friends may be addressing things. How do you think that healthcare professionals how might their own hidden or implicit biases affect how they approach the care or conversation of a person with CLL?
Unfortunately, this bias that they're the worried well, that they're someone who has a cancer diagnosis but won't ever need therapy. And so, it should be easier to cope with, or it should be less anxiety provoking to come into a clinic setting, or it's not that it's okay to miss something. So I think there's a challenge of thinking about anxiety and coping and mental health related to worry that definitely impacts this patient population. I think because there is such variability in terms of the disease, it's hard to know and start to understand which part of that is going to impact the individual. And so when someone may be in that more favorable prognostic factors, not needing therapy, it's a little bit different in terms of the approach of what their worries around financial considerations. They may not be thinking, I'm going to need to plan for treatment and coming to the clinic and transportation and potential hoteling if I'm coming from a distance. And then you have patients that are, in that more aggressive feature. And, as they start to understand that and start to recognize this is going to require maybe a really expensive medication, or multiple trips to a clinic, or time out of work, or time out of caregiving, or time out of what I thought was really important as part of my quality of life that may not have a dollar sign attached to it, but you definitely have to shift the mentality around. And so, it's thinking about that and understanding the goals of that patient and that individual is going to evolve and change, and what they're worried about and what they're concerned about or what they think is nominal or super important definitely is something that we have to center in our approach to how we support them and guide them to treatment or through treatment or in varying ways.
You've mentioned quite a bit about some of the common misconceptions about CLL around anxiety and the treatment trajectories. What are some of the other misconceptions that you can think of that you would want people to know about?
There's really well-established criteria for when to decide to treat. And so there's good evidence to guide clinicians to say this really warrants CLL-directed therapy and then go down the trajectory of which treatment strategy is the best. And so I think one misconception around CLL that even if white blood cell count is incredibly high, and I mean, I'm seeing total white blood cell count in the hundreds, in the 200s, that may not necessitate treatment. And so I think some of those guiding principles of what we utilize as criteria to proceed with treatment, there is good, well-established guidelines from the IWCLL group and others that really help us understand when we need to treat. And so I think that is oftentimes I get called from a lot of clinicians, their partners in care, and they say, the white count is 150. Does that mean I need treatment? And it doesn't always mean that it warrants treatment. So I think that's one of the big misconceptions with CLL, that patients, that's the one, while it's the diagnostic feature that kind of leads down this trajectory, it's not the only element that would necessitate kind of a change and a move towards potentially a treatment strategy.
That's a really important point. What's something else about this topic that's not often discussed, but you wish people knew more about?
I mentioned it a little bit earlier around early intervention studies that were not favorable in terms of they were negative. They said that if patients were treated early in their disease course, it didn't actually change their overall survival or progression-free survival, so time to another therapy. So I think that that's something that early intervention, we often think about that in the oncology world. If we treat it early, if we understand and identify this and move quickly, that's going to have benefit. And I think that there's this reassurance in some pieces that we've evaluated to try and see if earlier intervention and treating CLL or SLL early is beneficial. And those studies were actually the opposite. They just led to more adverse effects or treatment-related toxicities and subsequently. I think another piece that we don't often discuss is around, and I touched on it a little bit, around the immunoglobulins and the immune system, but CLL has a pretty significant impact on the immune dysfunction. And so patients with CLL, even if they are not on any type of active treatment, their immune system doesn't necessarily function fully. And so they're more likely to develop some upper respiratory infections or more easily develop, unfortunately, flu or COVID, some of those types of viruses, or take longer to clear an infection. And so oftentimes we think a lot about supporting patients to get vaccines and to have early evaluation if those symptoms develop, because you're more likely to develop, flu or COVID and such, rhinovirus, RSV, things like that. And so I think there's a component around the immune dysfunction that I think is really valuable for people to understand, that it's not contingent upon the treatment. It's really contingent upon the disease and mechanistically how the B cells are dysfunctional and don't provide that immunity that otherwise would be in a healthy B cell.
This has been really informative, and I've gotten a great refresher and learned a lot of new stuff. I have a couple more questions. What's some additional training or education that oncology nurses can utilize to stay current on this topic?
One of the resources that I think is really helpful is the ONS biomarker database. So I think that helps to understand some of these nuances related specifically to CLL. I also think that we have great partners with other organizations like NCCN, the Lymphoma Research Foundation, the CLL Society, Blood Cancer United organization in terms of a wealth of information, who really have a lot related to, we talked a lot about the active surveillance, but even more so around potential treatment options for these patients.
The resources that you just mentioned are great for the oncology nurses. They also have the patient-facing ones as well. And that would be great resources for both patients and healthcare professionals.
Yes. So I think that from a patient orientation, all of these organizations have a really strong support for patient-based education and really trying to meet them and give them really specific, validated, evidence-based guidance. And I also think for a lot of this, as I mentioned, a lot of the mental health component, and there's a lot of community groups and networking and resources around that. So I think it's a great partnership in terms of getting validated evidence-based information and connecting with individuals that have kind of that peer support, which I think can be really impactful and beneficial to patients to talk to others who have had a similar experience or kind of want to pursue additional questions. These are great avenues for getting great information that's trusted and I think geared in a way that's very digestible for patients and easily readable. But I also will say a lot of them come in other languages and they try to have videos as well as written resources. So all types of venues in terms of what everyone likes to listen and learn from.
Caitlin, it has been great talking with you about this great overview of CLL and SLL. Do you have any final comments for us?
No, I think this is the first step of a great conversation. And I really look forward to sharing more about SLL and CLL so that patients and nurses really feel comfortable with this information and understand the disease.
Thank you. Have a great day.
Thank you.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.